My name is Segel Aran, and I'm a pediatric neurologist in Shaare Zedek Medical Center, Jerusalem, Israel. In the next 20 minutes, I will briefly describe a possible role of the endocannabinoid system in ASD, in the pathogenesis of ASD. I will also discuss the current evidence for cannabinoid treatment in ASD, including the results of our still unpublished randomized study. After my talk, we will have time for comments and questions. So here are my disclosures, and while you are reading this, I want to thank the organizers for this opportunity. And I'm sorry, of course, that we cannot meet in person in this challenging year. Recently, there is a hype about marijuana, both recreational marijuana and medical marijuana. I prefer the term medical cannabis. It sounds more medicinal. I can understand why recreational marijuana is so popular. Not from a personal experience, but I can understand. But why is medical cannabis so popular? Apparently, some families prefer medical cannabis because it is perceived as natural and innocent and harmless, as opposed to the chemical drugs. I want to start this talk by emphasizing that this is not true. Cannabis has adverse events, especially in children. The brain is still under construction. Several studies indicate that consumption of recreational marijuana at a young age is associated with certain risks. There is a risk for addiction. During youth, this risk might reach 50% with the daily use. A mild cognitive decline might appear after years of heavy use of recreational marijuana, but this is still controversial. The more prominent risk is motivational loss, a decrease in the ability to raise enough willpower to fulfill one's goals. And most frightening is risk for psychosis and schizophrenia, which might be even higher in people with autism that are more prone to neuropsychiatric comorbidities. So why take unnecessary risks and even try medical cannabis in autism? The two main cannabinoids in the cannabis plant are tetrahydrocannabinol, THC, and cannabidiol, CBD. Tetrahydrocannabinol, THC, is a main psychoactive component. It causes a high feeling. THC is the very reason why people are using recreational marijuana. But it can also cause anxiety and psychosis and all the other risks that I've just mentioned. CBD, on the other hand, is not psychoactive. It is also considered to be antipsychotic and anxiolytic, and it is believed to reduce all the risks of the THC use. There are many different strains of cannabis, and each strain has a completely different impact on the brain. All the recreational strains and most of the medical strains contain very high THC and very low CBD concentrations. And these strains are indeed not recommended for children and for people with ASD. In ASD, we use strains with very high CBD and very low THC concentrations. And these strains are considered to be relatively safe. There are still risks, of course, but these risks are not unnecessary. The prevalence of autism is rapidly growing. And today in the United States, 1 out of 54 children is diagnosed with autism. The core symptoms of autism include persistent deficits in social communication and interaction, and restricted repetitive patterns of behavior and sensory anomalies. Unfortunately, despite all efforts, currently there is no established pharmacological treatment for the core symptoms of autism. Additionally, about half of the people with ASD also have prominent behavioral difficulties. And unfortunately, about 40% of them will continue to have severe behavioral difficulties despite proper behavioral and pharmacological treatments. This is a severe public health issue, and novel treatments are urgently needed. Preclinical studies suggest that the endocannabinoid system might be a good target for novel treatments. Several studies in different animal models of autism demonstrated alterations of the endocannabinoid system in the pathogenesis of autism and attenuation of the autistic symptoms by activation of the endocannabinoid system. The endocannabinoid system has many regulatory roles in our body during health and disease states, but the main effect of the endocannabinoid system is neuromodulation, modulation of neural activity. Our brain works through neuronal circuits. For example, if I want to raise my left hand, neuron number 7 will activate neuron number 77, that will activate neuron number 777. The contact points between the neurons are being called synapses. Many of the ASD-related genes regulate the activity in the synapses. We call it synaptic plasticity. The endocannabinoid system is a major regulator of synaptic plasticity. In a nutshell, if a certain brain circuit is overactive, endocannabinoids, the green triangles, are being released from precursors in the cell membrane of the postsynaptic neuron. The endocannabinoids activate the cannabinoid receptor on the presynaptic neuron, and the activated cannabinoid receptor stops the activity in this circuit. Let's see it in a short movie. When a certain brain circuit is overactive, the enzyme NAPPLD starts producing the endocannabinoid anandamide from precursors in the cell membrane of the postsynaptic neuron. The anandamide here crosses back the synapse, and binds the cannabinoid receptor in blue, which activates the G protein in green, which closes the calcium channels, opens the potassium channels, and stops the activity in the synapse. We and others found substantially lower endocannabinoid levels in the blood of children with autism compared with children with typical development. Again, we found a substantially lower endocannabinoid levels in the blood of children with ASD. Studies in animals suggest that the blood levels of endocannabinoids reflect the brain levels of the endocannabinoids. So this finding might be important. Several case series reported a substantial improvement in the behavior and even in the core symptoms of autism, in the social deficits, in children after using several strains of CBD-rich cannabis. But all of these studies were uncontrolled studies. And I want to remind you the famous saying of Dr. Archie Cochrane, that the plural of anecdote is not evidence. In fact, almost any treatment that was ever tried for any disorder was proven to be effective in uncontrolled studies, but most of these treatments failed later in a controlled study, in a placebo-controlled study. Uncontrolled trials should be interpreted very cautiously, and autism is no exception. We have seen this movie before, for example, with the secretary. So we moved on to a controlled study. This was a double-blind, randomized, placebo-controlled trial with 150 participants and 3 treatment options, 3 treatment arms. The first arm was a whole plant extract of a strain that contained 20 times more CBD than THC. The second arm was placebo. And the third arm was pure CBD and pure THC in the same ratio and dose as in arm A, but without other components of the cannabis plant, such as terpenes and flavonoids and other minor cannabinoids that might also contribute to the therapeutic effect in what we call an entourage effect. So arm A contained a whole plant extract, everything that was in the plant, CBD, THC, minor cannabinoids, terpenes, flavonoids, and so on. And arm C contained only the CBD and the THC with nothing less. This was to test the entourage effect, entourage theory. There were 2 treatment periods of 12 weeks each, separated by a 4 weeks washout period. 50 participants have been randomized to receive a whole plant extract in the first treatment period, 50 pure cannabinoids, and 50 placebo, and a different treatment in the second treatment period. The baseline assessments included EDOS and Vineland. The 2 primary outcome measures addressed the behavioral problems. The clinician global impression of improvement in the specific behavioral problems of the child, and the home situation questionnaire, which taps disruptive behaviors that are common in the general ASD population. There were also 2 secondary outcome measures, the social responsiveness scale, which is an indication of core symptoms severity, and the Autism Parenting Stress Index, which is mostly influenced by the child behavior. Adverse events were assessed every 4 weeks using a 34 items questionnaire. As expected, 20% of our cohort were girls. 90% of our participants had severe autistic symptoms or low adaptive level. We had a 12% attrition that was well distributed across the 3 study arms, as you can see. There were no treatment-related severe adverse events, no severe adverse events. The prevalence of mild adverse events in green was quite similar in the 3 treatment arms, cannabinoids and placebo. But moderate adverse events in pink were somewhat more prevalent in the cannabinoid treatments compared with the placebo. The most common adverse events were sleepiness and tiredness. You can see here that they were more prevalent in the cannabinoid treatments. Whole plant extract, the red column, and pure cannabinoids, the gray column, compared with the placebo, blue stripes. Sleepiness, mild and moderate, tiredness, mild and moderate. Other adverse events that were more prevalent in the cannabinoid treatments were decreased appetite, weight loss, and maybe also euphoria. All the other 30 adverse events that were assessed were not more prevalent in the cannabinoid treatments compared with the placebo. It was the same prevalence. For the behavioral problems, there was no difference between the 2 cannabinoid arms, whole plant extract in red and pure cannabinoids in gray. About half of the participants substantially improved in the behavioral assessment following the cannabinoid treatment, with no significant difference between the whole plant extract and the pure cannabinoids. So we didn't find an entourage effect. When we have compared the cannabinoid treatments together, the green column, and the placebo, we found a significant difference in the first treatment period and in the second treatment period. About half of the participants either much improved or very much improved following the cannabinoid treatment, compared with about a fifth of the participants who received placebo. This difference between the cannabinoids and the placebo was less prominent in the other outcome measures, in the home situation questionnaire ASD and the Autism Parenting Stress Index. Surprisingly, we also found an improvement in the core symptoms of autism, the social deficits and the repetitive restricted behaviors. You can see no significant difference between the whole plant extract in red and the pure cannabinoids first period and second period, but a significant difference between the cannabinoids, green column, and the placebo in the first period and in the second period. Notably, cannabinoid treatments also caused a decrease in the BMI in the first period and in the second period, as opposed to the placebo, who caused an increase in the BMI. And the difference is, of course, significant. So cannabinoids also caused a decrease in the BMI. And this decrease was mostly in overweight children. So to sum up, is marijuana the world's most effective treatment for autism? This is a real headline from Newsweek. So in my opinion, the answer is no. But cannabinoids might expand our toolbox for treating behavioral problems in children with autism, especially overweight children. And there is also an indication for improvement in the core symptoms of autism. Are we there yet? Of course not. Further studies are required, and some of them are already ongoing. Our study suggested that pure cannabinoids were as effective as whole plant extract. But again, this should be examined in further studies. Do we need some THC there to keep the efficacy, especially for the social deficits? Or maybe we can just use pure CBD, which is much safer. We don't know yet. We will look into that in our next studies. Compared with epilepsy studies, we usually need a lower dose of CBD. Usually 5 to 7 milligrams per kilogram per day is enough for autism. So thank you, and we will have now a time for comments and for questions. Thank you.
Thank you so much, Dr. Aran, for a really fascinating presentation. We do have a couple of questions that have come up in the Whova app. Let me pull those up. So the first question, do benefits of cannabinoid treatment correlate with plasma levels of cannabinoids?
Okay, so I just repeat the question. This was a great question. If we found any correlation or any association between lower levels of endocannabinoid, of blood endocannabinoid at baseline, and higher improvement following cannabinoid treatment. So unfortunately, we didn't find the correlation. We are not sure why, but there was not a good correlation. Maybe something in our methods to assess the cannabinoids were not so great, or maybe there are many other factors that influence this, but we couldn't find a significant correlation between higher improvement and lower endocannabinoid levels at baseline.
That's fascinating. The next question, Dr. Aran, is assuming a person's issues are at least contributed to by low cannabinoid, endocannabinoid levels, above and beyond utilizing cannabinoids, would you kindly speak to the potential for use of a fatty acid amide hydrolase inhibitor, either instead of cannabinoid treatment or in combination?
So I'm not familiar with studies that assessed this, so I don't know if I know about studies assessed these separately, so that assessed many kinds of fatty acids, especially omega-3 fatty acids, and autism or epilepsy and ADHD, and studies of CBD and epilepsy, of course, and also autism. But I don't know about the cross effects between them. So if this was studies, I'm not aware of that.
Okay, thank you. Another great question. Can you please elaborate on which core ASD symptoms you expect CBD to impact more or less? What about speech in non-speaking kids?
Okay, so I want first to be maybe more cautious. We did find an improvement in the SRS, which is an indication of the core symptoms, but SRS is only an indication of the core symptoms. And we did find an improvement both in the RRBs, in the repetitive and restricted behaviors, and in the social deficits. So in the both of the sections of the SRS, but we didn't assess speech by itself. Parents did report improvement in speech. Again, we cannot say if this is due to the CBD, if this is due to or the combination, or if this is due maybe to other non-direct effects of this whole improvement in the behavior. Maybe it's not a direct improvement. Maybe the child was just more prone to learn. But many parents report improvement in the communication, including in the speech, in the expressed, and in language by general, but we don't know yet. We didn't assess it directly.
Thank you. The next question, let's see here. Though this is not your area of expertise, do you have an idea what age children in general are diagnosed in Israel with autism?
Yes, so I do know that I think that this is true for all the Western world. So I think now the average age is between 2 and 3, but many children are being diagnosed between 1 and 2 years. So very early, boys earlier than girls, but I think that this is true for all the Western world.
Okay. And do you have any thoughts about using PEA along with CBD?
PEA?
Phenylethanol.
You mean one of the endocannabinoids. So we had thoughts about combination of CBD with many other compounds. PEA was one of them. Actually, I am aware of one study from Saudi Arabia, I think, about PEA in autism. It was an impressive study which assessed risperidone with PEA and risperidone by itself, head-to-head, and PEA was shown to be more effective. It was a relatively small study, but it was significant. The results were significant. So we have thought about that. There are so many things that we don't know. We are just trying to scratch now the surface of this entire issue. So this is a good question, but there are many things that should be to do in the next years.
Thank you. And I think we have one final question, just in time. In participants with aggression and anxiety in your trials, did these go down?
So aggression, yes. There are also studies in animal models of autism which demonstrate that CBD can lower down the aggression. And also in our study, we found that the most significant effect was on the aggression. Unfortunately for the anxiety, we thought that we will have higher effect on the anxiety because CBD is considered to be anxiolytic in many other studies, but actually we didn't find such a prominent effect on the anxiety. The effect on the aggression was higher.